Okay, so good morning, good evening, or good afternoon, depending on where you're tuning in from. I guess it's just morning in the US where I am, and we're in the afternoon, evening hours everywhere else. We are delighted to be back with another session here, and we have Dr. Francesco Pichi from the Cleveland Clinic in Abu Dhabi and Dr. Marion Munk from Bern, Switzerland. So thank you both for taking the time to join us today.
Thank you very much.
Thank you very much for the kind invitation.
No, so as we were chatting, it's all ours is the pleasure. So and our audience is going to learn quite a bit, as the uveitis is a great topic here to get on, and I think it's usually underdone at the meetings, or always put on that either just at the very last day. So I'm kind of great to have this in the middle of the day here for most people to get it. So as we have the participants still logging in and coming on, let's just kind of go over a few things. And so Francisco, since you're the first person we've had on from the Middle East, what are things like there with this COVID-19 time, and how is your clinic dealing with the changes?
So right now they are getting back to normal. I would say my clinic is now at 75% capacity. I have to say the government here was quite on top of things. So and I'm comparing to Italy because I'm Italian. So I was seeing things in Italy, and they were closing down things in March, and the government here closed at the same time. So for 1.5 months, we had no clinic, just urgent cases. And you know, it's quite tough with uveitis patients, especially. I'm sure Marion has had the same experience because they require constant blood work or assessment of inflammation. So I had to have some patients coming. It's a constant reassurance because they are immunosuppressed sometimes. So they worry more than normal patients. But we got through it, and I would say 3 weeks ago we opened up, and now I'm starting again. I feel my patients are now quite comfortable coming to the hospital. It's probably how the clinic is running things. So they don't seem scared. There's social distancing. They are spread out through the day, all wearing masks. There's a continuous cleaning of everything. So they feel pretty comfortable right now.
And so, Dr. Munk, coming over to you, and then kind of an interesting spot. I got to work with a uveitis specialist early in my career, and we used to joke that he was the real doctor in the practice because he had to use the real medications and the stuff that really was putting people immunosuppressed. How was that with your patients, in that in between seeing them and how you brought them in? We almost did our own clinical trials by seeing how long we could go between visits, but what was it like for you and your clinics with this?
Yeah, it was quite similar with, as Dr. Pichi has mentioned or described. So we also, in this really critical period and this lockdown, we really only saw emergency cases. And we really had to decrease the volume of the clinic substantially. So really only emergency cases were seen. But of course, especially the uveitis people and patients were very worried, as Dr. Pichi has mentioned, in particular because of the fact that a lot of them are taking not only one immunosuppressants, but sometimes maybe 2 or 3 different immunosuppressants. And so I think we were very busy in taking phone calls and trying to educate them what to do, which was particularly hard because we also didn't know what's the right thing, what's the right thing to do. And but we formed a kind of it was an activity based on the IUSG, the International Uveitis Society. So we tried to come up with some guidelines how we should treat and how we should move forward in terms of patients under immunosuppressants and patients who are more at risk to get more severe disease, COVID disease. And I think with that we managed the situation quite well, and now we are also back or getting back to the new normal. In clinic, I think we have reopened for 4 weeks now. In terms of the volume, I think it's going to be similar to Dr. Pichi's clinic, like 75 to 80%. And as I said, people and patients are quite comfortable coming to clinic because they really feel that it's taken care of. Everybody's wearing masks, and we have cleaning is there all the time. So I think they're not afraid of coming into clinic and being seen again. Yeah.
I'm trying to refer to this as the temporary normal. I don't want this to become the new standard. So as we're going to put up a polling question here for the audience, but while we're there, Dr. Pichi, how about telemedicine? So as we go through this question here is, which do you believe is the most important feature in an OCTA device? You can choose up to 3. We'll let the audience go through and choose these while we discuss it a little bit. But how about telemedicine in the Cleveland Clinic? Was that something that was implemented in the Abu Dhabi area?
Yeah, it was something that we started. I think we started it, but we are it's not maybe just us. We are a bit behind, because if you want to implement telemedicine as far as uveitis or even retina, you need a way to assess the patient. Because for me, just to have a phone call or a video call with a patient without the ability to check the inflammation. So that's what we are trying to do here. So we're trying to spread imaging machines all around the Emirates, so that if this happens again, and hopefully will not, but patient will have a chance to go like 1 kilometer from their house, just drive 10 minutes, get a quick scan, then I can review and discuss with the patient. That's the way forward. That's what we were missing this time around.
Okay, I'm going to go ahead and broadcast the answer to that. And while we're doing that, we can see image resolution, which is key. Obviously, you can't have a lot of the other stuff doesn't work without having a good image to start with. So I definitely agree with what we're seeing on a lot of this here. But Dr. Munk, one last thing before we get into the presentation is, as I know you chair a reading center, how were clinical trials impacted during this? Did we see a significant decline? Is it going to impact the results, you think, long-term with some of these changes?
Yes, definitely. I think, interestingly, the larger trials, like the phase 3 trials, I didn't have the impression that there was we still had images coming in, and they were still seeing patients. However, there were a lot of smaller trials which really had problems with the situation, and some of the trials were really kind of stopped interim wise, and it's not a question whether they will really reopen. Yeah, this is the one point. And of course the other point is because even in the large trials or in the phase 3 trials, a lot of patients didn't come in, so there were a lot of protocol deviations and violations here. And yeah, and so we will see how much impact this really has on the final analysis of the data, but it will definitely have some impact.
Interesting. I think there's one more polling question before we start, but as people are filling this out, OCT used to assist imaging management. Go ahead and choose which diseases. You can choose multiple that you believe are best imaged with an OCTA. And while we're doing that, just for any of the audience members, during the presentation, there is a Q&A button down below. If you could press that and put your questions there, we will try to answer them in between the presentations and after. So let's go ahead and broadcast which we believe is the best image, best disease managed with OCTA. Let's see what those answers come up with. And it's always curious to see after your presentation. So CNV, obviously the big leader. We'll see how much of this this changes based upon the presentations that we get here. So I'm going to go ahead and mute my camera again. If there are any questions, please put them in the Q&A. We'll answer them. I'll go ahead and mute myself and turn our cameras off here, and we'll be back in just a minute. I'm looking forward to the presentation.
So, ladies and gentlemen, tonight I'm going to present 3 cases to highlight the importance of OCT angiography when you're dealing with the choroidal disease, and in particular with uveitis. Now, these are my disclaimer. So we're going to start with one case that shows very well how OCT angiography goes hand to hand with dye-based angiography when you're dealing with the posterior uveitis. This is the case of a 38-year-old Arabic male. He presented to our clinic 5 days of decreased vision, and nothing remarkable in the past medical history and past ocular history. The best corrected visual acuity in the right eye is 20/40 and 20/50 in the left eye. Pressure is fine in both eyes, and there's no degree of inflammation in the anterior segment of the eye. When we look at the back of the eye, these are 2 retina photos of the right and the left eye. Now, first of all, we look at the optic disc. You can see on the nasal side of the optic disc, there is some kind of fibrotic appearance, which make us think that there was a component of neuroretinitis, which is now resolving. But the most striking feature here are these round, white, deep, choroidal small lesions that are actually present in both eyes. Now, when we deal with the choroidal disease, we always go for dye-based angiography, and in particular, ICG angiography. So the patient was sent for combined FA and ICG, and here are the early frames for the right eye. You can see nothing majorly remarkable in the FA on the left side of the screen, maybe slightly hot disc, but what's striking is on the right side of the screen, the ICG appearance. So there are lots of small hypofluorescent lesions diffused along the arcades and all over the posterior pole. And in the intermediate phase, they change in number, they're less in number, but they're more and more visible, and they persist during the late phases of the ICG. Now, when we have in the left eye, we have the same appearance with a small hypofluorescent lesion along the inferior arcades. Now, when we deal with this particular kind of ICG appearance, the diagnosis is choroidal granulomas. Now, choroidal granulomas are usually present in three kinds of disease in uveitis. One is VKH, one is sarcoidosis, and one is tuberculosis. So the patient was sent to the lab, and we got an ACE, quantiferon gold, to check for sarcoidosis and for tuberculosis, and then sent the patient to imaging. We to check the status of the lungs. The quantiferon gold came positive and the chest CT negative, so the diagnosis was of TB choroiditis with no lung involvement. Now, what is a granuloma in the choroid? A granuloma is a clot of inflammatory cell which is surrounding the bacteria. So as such, it is a mass in the choroid and it's occupying space. When it's occupying space, it's also compressing the vessels of the chorocapillaris and of the choroid. So our question was, can we use OCT angiography in this patient to detect those granulomas which are occupying spaces and blocking the flow? Now, this is the 12 by 12 swept source OCTA of the right eye of this patient. This is the superficial capillary plexus. And if we go deep into the chorocapillaris, but mostly into the choroid, you see lots of these flow voids, round, small in appearance, which mirror what we were seeing in ICG. We take a slab of the OCT B scan with a superimposed flow, and you see that this flow void, one of these flow voids, for example, corresponds very well to a lesion in the choroid, which is a mass, and it's blocking the blood flow. So this is a granuloma of the choroid. We have the same appearance in the left eye. This is the ICG we were seeing before with the hyperfluorescent granulomas, and you see very well how OCTA of the choroid is mirroring this appearance with flow voids that are corresponding to granulomas. Now, the patient, of course, was sent to the infectious disease doctor, who started on quadruple therapy for the tuberculosis and on prednisone. And this is the evolution of the patient through multimodal imaging. Now, here we have on the top row the ICG at baseline, and on the bottom row the OCTA of the choroid at baseline, highlighting the choroidal granulomas. You can see after 6 months, the choroidal granulomas on the ICG have mostly completely resolved. There are just a bunch here, and they have resolved mostly completely in the OCTA of the choroid. And once again, the lesion that we were seeing on the corresponding B scan with a superimposed flow, so this mass blocking the blood flow of the choroid, is completely resolved at 6 months. So the resolution, of course, is not just in the right eye, but also in the left eye. You see this is the early ICG on your left side at 6 months, and this is the OCTA of the chorocapillarity at 6 months, and there are mostly no granulomas left. And the late ICG, maybe a couple of granulomas here and there, which are reflected very well on the OCTA of the chorocapillaris. So what are the take-home points of this case? ICGA still is the clinical standard at baseline for granulomatous choroiditis as TB and sarcoidosis, but it can be accompanied by swept source OCTA. But when you are following these patients, serial ICG angiography can be dangerous, sometimes life-threatening, and they're time-consuming as well, while a swept source OCTA can be the perfect way to follow up these patients. Moving on to case 2, now that we have proven that swept source OCTA can go hand-to-hand with dye-based angiography, our question is, can we just use OCTA in some cases and completely forget about dye-based angiography? Well, this is a case of a 28-year-old Arabic male. He came to the emergency department with floaters and with a blurry vision in the left eye. The past ocular medical history completely unremarkable. Right eye, you can see vision, pressure, and the appearance of the front are completely normal. While the left eye, the vision is quite impaired. It's a 2200 vision, and the pressure is slightly higher than we would want. And there is inflammation in the front. There's 2+ cells in the anterior chamber and 2+ cells in the anterior vitreous. This is the appearance of the left eye, the retina appearance, and of course we want to concentrate on this particular white lesion. When we see such lesion, for most of us it's a straightforward diagnosis. We have a white area, which means most of the time means an infection, and we have a small scar next to it. And if we scan with OCT through the lesion, you see that the retina has a completely disorganized anatomy, which makes you think of a retinitis. And there is a blocking of the underlying choroid. So the choroid is affected as well. So this is a retinochoroiditis or chororetinitis, whatever you prefer. So when you have this kind of appearance, you always send the patient for IgM and IgG to look for toxoplasmosis, and in this case, they came out positive. So the diagnosis is quite straightforward. This is a retinochoroiditis secondary to infection from Toxoplasma gondii. But now the question is, how do we follow this patient? Should we get fluorescein and ICG at baseline and maybe follow the patient like this? Well, I was a big supporter of dye-based angiography for toxo, because ICG can actually highlight satellite of infection and like Achiriolis arteritis, so infection of the vessels. But in this particular patient, I actually used for the first time OCT angiography just to follow the patient. Now you can see the lesion and you can see the swept source OCTA of the superficial capillary plexus highlighting very, very well the areas of retinitis. So we have a way which does not involve a dye to measure and follow up the area of involvement of the retinal vessels. And if we go deeper, now we have a perfect picture of the focus of infection at the level of the choroid with all the satellites of infection next to it. Now, OCTA, it's not the only tool that we can use. Swept source gives us a perfect visualization of the vitreous. And one of the hot topics in uveitis right now is the subjectiveness of measuring inflammation. We measure inflammation by counting cells at the slit lamp, but this is very, very subjective. It changes from one physician to the other. But using OCT, swept source OCT, you see very, very well. You can actually count the cells in the vitreous, and you can follow up. So the patient, after 1 week, you see the decrease in the inflammatory cells in the vitreous. After 1 more week, you see there are less and less inflammatory cells, and at the 1 month follow-up, they're mostly resolved. So this is a great way, an objective way to assess the inflammation of the vitreous. Now, in this patient, I did not use dye-based angiography at baseline, and I did follow and monitor this patient just with OCTA. Let me show you the results. So this, on the top row, the patient at baseline. On the bottom row, the patient after 1 month of the correct antibiotic therapy with Bactrim DS and cortisone. Now you see that the lesion is mostly fibrotic, and it's nearly completely healed. And this is mirrored at the level of the retina by a restoration of the blood flow in most of the areas of the retinitis, and you can see the focus of choroidal infection that was present as baseline is mostly gone on the OCTA of the choroid. This is mirrored as well in a normal B scan, where there is a consolidation of the area of retinitis and the choroidal architecture is mostly restored. So what is the take-home point here? Well, swept source OCTA can replace in some diseases such as toxoplasmosis the dye-based angiography in monitoring the improvement of patients with retinochoroiditis. And now one last case. In this case, very quick case, I want to highlight how swept source and OCT angiography can be used to prove the non-involvement of the choroid and to prove where the disease is actually localized. This is a 19-year-old Arabic female. Since 6 months, she started developing a scotoma in the left eye with flashing lights, and she was sent to us with for a second opinion. Nothing remarkable in past medical and ocular history. The vision is quite good. She's 20/20 in the right, and the left eye, which is the involved eye, is missing just a couple of letters, and the pressure is fine. No inflammation in the anterior chamber. This is the appearance of the left eye. Now, I want to highlight, first of all, this area. So you have a white area around the optic nerve, and you have all these small whitish area which are located deeper into the retina, not right at the level of the choroid, but in the deep retina. And if we scan through with normal SD-OCT, you can see that these area of annular area of involvement around the optic nerve corresponds to a loss of the photoreceptors of the ellipsoid zone. And you can see that all these white small dots correspond to small areas of ellipsoid zone loss, so loss of the photoreceptors. So of course, when you see such kind of posterior uveitis, if we want to call it, you go straight away for autofluorescence. Now, autofluorescence here is showing a hyper-autofluorescent corresponding to the annular disease around the nerve. Why is it hyper-autofluorescence? It's a disease of the ellipsoid, of the photoreceptors, so it's just unmasking the underlying normal autofluorescence of the retinal pigment epithelium. And then all the other satellite lesions that we were seeing, they were very difficult to catch on the fundus photo, but here they're very clear. They correspond to areas of loss of the photoreceptors and unmasking of the RPE autofluorescence. We go, of course, for fluorescein and ICG, which is not telling us a lot. You see, ICG is showing no involvement of the choroid. And fluorescein is showing mild staining of these areas, but it's not picking up all these small satellite lesions. So our question is, do we have other ways, non-invasive ways, to prove where the lesions are located, at which level of the retina, and to prove that there's no choroidal involvement? Yes, we do. So wide field ANFAS OCT, this is a composite of 215/9 swept source OCT ANFAS, and this is a slab at the level of the ellipsoid zone. So this is the slab of the disease part of the retina. And you can see very well how these hyperreflective areas highlight the loss of the photoreceptors. So we have a confirmation through ANFAS OCT that the disease is at the level of the photoreceptors. Now, how can we exclude the involvement of the choroid without ICG? Well, the way we did before for the other patients. We have here a composite of 5 12/12 OCTA at the level of the choroid, and you can see the choroid is completely intact. So now, through multimodal imaging, we can put together a diagnostic hypothesis. Now, autofluorescence and the ANFAS OCT are confirming that there's just involvement of the photoreceptors. ICGA and the swept source OCT composite are excluding any choroidal disease. So in my mind, the diagnosis was either mute, but it's very unlikely because there's no involvement of the RPE. But more, I'm pointing towards one of those particular kind of disease, which is AZOR, acute zonal occult outer retinopathy, or ANOR, the annular form of the retinopathy. The patient was followed and she's stable. She wasn't treated because we don't know enough about this disease. And after all, she's 20/20. So the take-home point of this particular case is that we can go wide field, both with UNFAS and with swept source OCTA, covering nearly 90 degrees of the retina. And UNFAS OCT can actually detect the layer which is affected in these particular entities, whether it is the ellipsoid zone, the choroid, or the outer retina. And finally, swept source OCTA is a valid alternative to ICG to exclude or confirm the choroidal involvement, in particular posterior uveitis. And with this, I thank you for your attention. And this is a composite of a swept source OCTA of the choroid. And you can see it covers most of what we can see with a wide field ICG. Thank you very much for your attention.
So thank you so much for that presentation, Dr. Pichi. Go ahead and turn our cameras on here, and we have a few questions coming in. So first thing I have to say is that I've seen this presentation prior to broadcasting it on Zoom here, and the broadcast didn't give some of those images the best visibility as I've seen them before. So I do apologize. Zoom, I don't think, considered themselves to be the essential ophthalmic distribution for some of this, and I think some of the technicalities that are there we're seeing. So one of the questions that did come in, though, is when you see white, it says, does the retinal whitening prevent visualization of flow? It doesn't mean that it's not there. And I think it's more of a technical question with the OCT. So what are your thoughts around that, both of you?
So yeah, absolutely. An area of decreased signal on OCTA does not mean ischemia for sure. It can mean that the blood flow is too slow to be detected, first of all. And then it can also be an artifact. But here we're talking about a swept source OCTA. And one more thing is that if looking at those color photos, the focus of toxoplasmosis was much, much smaller compared to the area of decreased flow on OCTA. So of course we have to take everything we see on OCT angiography with a grain of salt so far, because we need to, we are discovering more and more every time. So we need to know more, but I'm quite confident right now when I see such cases using a swept source OCTA to follow up the patient instead of using dye testing.
And I think in addition, it's also always good to, when you see an area of flow void or flow attenuation, that you just look at the structural on-fast image just to make sure what you see this kind of shattering or blockage in the structure image as well. Or, I mean, to be more precise, you could even look at each individual B scan or go to the area where this flow attenuation is and just have a look at the individual flow B scans to really see and confirm what you've seen to the on-fast or C scan.
Now on case 3 there, Dr. Pichi, was in your differential, I can't remember what was there, but was MUDES in consideration? That's one of the questions we're seeing is, could that have been a MUDES case? So
I have an advantage over Dr. Lujan because I've been following the patient now for 6 months, and the patient is exactly stable like this. So it was high in my differential in the beginning, I have to say. The ICG was never so abnormal. I may disagree on that, but looking at the B scan OCT, the RPE that we see in MUDES is slightly more mottled, and that's one of the causes of the hypofluorescent that we see with ICG. So the RPE in this case was completely intact, and it was just a disease, seemed to me at least, a disease of the photoreceptors. And then part of the differential was AZOR because of the pattern and the fact that the patient stayed exactly like this with no progression at all. But I agree, it should be high on your differential MUDES.
And then a question. Go ahead.
No, I just wanted to add to this case because I think it's very interesting. And usually the patients, for example, if it's AZOR, come in and then they ask whether, you know, their visual acuity decrease or their vision decrease or their blind spot, it remains or not. And so it's sometimes very useful also to look at the outer nuclear layer thickness. So if the outer nuclear layer is completely gone, in these cases, in the area above the photoreceptor loss, you can be quite sure that there will be no photoreceptors coming back. While if you have some outer nuclear layer left, you can tell the patient that there is a chance that he's gonna improve again, or it's worth trying even some steroids in these kind of patients. Of course, then it's a matter of discussion whether it's a real azor or it's something else. But yeah, it's worth having a look.
Sure. And so here's a question about the use of OCTA in toxoplasmosis. It says, what's the real indication? But I think we're trying to figure out what's the real advantage of imaging that way versus just following it. And maybe we don't know yet, but I'd love to hear your response.
So my experience with toxo is that sometimes you get foci of the infection which are not as close as you would think to the main focus. And those are the ones that you detect with ICG. And that's where swept source OCTA can help without, so you don't need to make the patient undergo an ICG, but then you can monitor, you can see if there are foci of infection far away from the main one, and then follow them through time and see if they improve with the correct antibiotic therapy.
Now, obviously, we've seen the advantages of some of the swept source technology you've shown with the penetration of the cord, but this question is, can SD-OCT be useful in the evaluation of cord, or is it only for swept source?
That's a good question. I have to say that in such cases, I would rather go with swept source if available, because of those issues we were talking about before. So because of masking from the retinitis above, and because of the penetration. So if available, swept source is a better option in such cases, because we're discussing choroidal diseases here, or mixed choroidal and retinal diseases.
Kind of a good, better, best method here. Huh? We have the best is obviously the Plex Elite where you're showing the images. And okay, so I think we have a few more questions here that we'll get to. We do have another poll question I believe we're going to show here. So how confident are you in your current subjective assessment of the vitreous cells and flare? This is always a good question for the uveitis specialist. And again, it's definitely a subjective measurement on today's environment. How long do you think it takes to get real comfortable with assessing cell and flare, in your opinion?
For me, a full year of uveitis fellowship at least. And I know when I did my fellowship in Cleveland, my mentor, Corinne Lauder, was giving me such a hard time all the time because my measurements of cells in the AC or in the back was not the same as hers. And even when I got slightly better, they were, they were similar, but not exactly the same sometimes.
Dr. Munk?
So I think my reproducibility in terms of the assessment is quite good. However, because of the fact that a lot of different residents are seeing a patient, usually, especially if the patient has 0.5 plus cells, so ranging from 1 to 5, I always force them to really write down the number of cells. And to be a little bit more descriptive, that the next time when the patient comes in and another resident is seeing the patients, that we can really kind of have some comparison. And another thing which I'm usually doing, I'm always doing laser flare in addition to it.
So I have to say that we need an objective way of measuring inflammation just to save Dr. Munk's residence from her, I think, right?
So
I'm very nice. I always bring chocolate.
One more question before we go to the next presentation is, are we able to see granulomas, let's say with EDI imaging and maybe using the en face view of the image that's created there, or is it better seen with the en face view from the OCTA?
So that's a great question. There are two papers published in Retina, I think, by Alessandro Invernizzi, who was my co-author in that paper. And in the beginning, they were looking at them with the EDI, and there are clear signs of hypertransmission behind the granuloma in EDI. However, if the granuloma is too small, it's very difficult, even for a trained specialist, to detect it. When we did that study, we also looked at a corresponding EDI scan, and even for two trained specialists in imaging, it was impossibly difficult to detect them. And the agreement between the two readers for EDI was very, very low, like 0.4.
Great. Well, Dr. Munk, we're looking forward to your presentation now, and I'm sure we'll be back with some more questions afterwards. So again, I'm going to go ahead and turn my camera off here, and thank you again.
Ladies and gentlemen, good morning, good afternoon, and good evening. It's a great pleasure for me to present today OCTA Interpretation, a case-based analysis of uveal diseases. These are my financial disclosures relevant to this talk. I'm a consultant for ZEISS and have received financial compensation for this presentation. In the upcoming talk, I will cover some challenges which we usually have to target in daily uveitis clinic. One of them is to differentiate inflammatory CNV from inflammatory lesions using FA and OCT. In particular, if you're dealing with a type 1 lesion, it's very often very hard to differentiate it when only using FA. And sometimes you can also have an active CNV in the patient, but you do not have any intraretinal or subretinal fluid present in the OCT, which also makes it very hard to differentiate. And another point is that it's sometimes hard to identify disease activity and progression in chronic uveitis cases. For example, when we think of birdshot or serpiginous cases, it's sometimes really hard to say whether the lesion have grown or there are more lesion present when you follow up the patients. And of course, the FA and ICG are very time-consuming examinations, and you can't perform them every time the patient comes in for a workup and for an examination. So I will show you how you can use OCTA and wide field OCT to help you differentiate inflammatory CNV from inflammatory lesions in uveitis patients, and also how you can use these modalities to add to identifying activity and progression in chronic uveitis. And last but not least, you can use it as a substitute to assess activity and choroidal involvement instead of FA and ICG. First case I want to present is an 18-year-old Caucasian male. He had blurred vision since about 2 days in his left eye, and he showed up in our emergency clinic on Saturday morning. Actually, his workup and his history was negative or unremarkable. The only thing which is notable is that he was in the army since about 6 months and previously had an intensive workup in terms of own infectious and a lot of infectious diseases. His vision in the left eye was 20/40, and everything was unremarkable, but in the left eye he showed vitreal cells, 1+, and multifocal yellowish chororetinal lesions temporal to the fovea, and also a small hemorrhage which was present there. So based on what we saw on the exam, we worked him up, and we found him to have a monocytosis. He was negative for TB or syphilis, and also there was no hint that he may have sarcoidosis. The chest X-ray was also unremarkable, but because of the fact that he had a toxoplasmosis serology previously before he entered the army, which was negative, we also did a serology in toxoplasmosis, and this showed to be IgG and IgM positive, and also showed an intermediate IgG avidity, which told you that actually the patient was actually having or just recently had a toxoplasmosis infection. Based on that fact, we started him on Bactrim Forte twice a day. And this is how he looked 2 days later in clinic. So the right eye was unremarkable, but when we look at the left side, you can see that there are multifocal choroidal lesions present here. And here it's more grayish, here more yellowish. And you can also appreciate, if you look very closely, a small hemorrhage present. On the Francesco angiography, you see an early, well-circumscribed hyperfluorescent lesions present here and late leakage. And also in ICG, you can appreciate the choroidal lesions. So the challenge here is now, when you look at the fluorescein angiography, you may think this is one large type 2 lesion present here, type 2 CNV lesion, which you can see here well circumscribed in the early phases and late leakage in the late frames of A. However, when you look at the OCTA, you can actually see that this is actually only one CNV lesion present, while the other one is only a choroidal inflammatory lesion without any CNV present. How the OCT, like, the patient had subretinal hyperreflective material, some subretinal fluid. This was the central scan, and this was a scan just a little bit more superiorly, where you can appreciate more multifocal punched out lesions. The patient had, and on a presentation, actually only 2 differential diagnoses. One is ocular toxoplasmosis, in particular a very rare subtype called punctate outer retinal toxoplasmosis, or as a differential secondary CNV in PIC. So it could have been that that secondary CNV in PIC is present, and the toxoplasmosis infection was just an incidental finding, because we have to consider that usually toxoplasmosis infection, only in 2% of the cases, you will really have also ocular involvement. So this may be possible too. So we treated him for ocular toxoplasmosis and continued with Bactrim forte. And of course, he was also treated with intravitreal anti-VEGF injections. And this is how he looked at like at the last follow-up. You can see here that the CNV lesion is not active anymore. So here's only fibrosis. And you see that also the lesion has not grown in size, and the patient was back to 2016 and so far hasn't developed any recurrence in terms of CNV, and also not in terms of any ocular toxoplasmosis. The second case I want to share with you is actually a little bit even more complex. It was a 49-year-old Caucasian woman who had a history of kidney transplant, 2001. Because of a nephropathy she had. Unfortunately, the donor was positive for CMV and shows it developed a recurrent CMV infection, particularly gastrointestinally, since 2001. She was treated with ganacyclovir, valacyclovir, and foscarnet because she had a CMV resistance, which was also detected. In July 2019, it was actually the first time where she also showed a CMV retinitis, and for this she was treated with intravitreal foscarnet. You have to keep in mind that because of the kidney transplant, the patient was also on immunosuppressant therapy, which was Sandimune and Spiricord. And of course, that we always have to keep in mind these patients to also have some bacterial opportunistic infections. We had a look in terms of her, blood cells, and you can see that she was slightly immune compromised based on her disease modifying drugs and immunosuppressants. This is how she looked like in clinic when she presented initially. You can see very characteristic the CMV lesions present in both eyes, like the retinitis lesions present as yellowish lesions here in adjunction with the hemorrhage present. So it's usually described as pizza lesions. You can see it here. But when you have a closer look in the macular region, you can also appreciate actually choroidal lesions, which is really untypical for a CMV retinitis because per definition, it's a retinitis and not a choroiditis. Also, when we look at the fluorescein angiography, you see characteristic changes which are in line with the retinitis. So you see slight vasculitis, you can see ischemic areas in the areas of retinitis, and you can also see blockage due to the retinitis. But when we have a closer look in the macular region, you can also appreciate inflammatory choroidal lesions here. And here again, you see in the early and in the late frames that you have a well-circumscribed early hyperfluorescence in the FA and the late leakage. But when we have a closer look at using the OCTA, we actually can see that these lesions here, sorry, this lesion and this lesion here is actually an inflammatory lesion, and only the lesion here is really corresponding to a secondary CNV. In the left eye, it's more straightforward because you can see here that the patient has a secondary CNV present in the OCTA, which nicely corresponds to the type 2 CNV present in the early and in the late FA frames. When we look at the OCT and the normal B scans, we can see that there's no fluid present in the right eye, so you only have the CNV without any activity. However, in the left eye, you have the lesion accompanied with intraretinal fluid. So based on what we found, we diagnosed a patient with multifocal choroiditis and secondary CNV in a patient with recurrent CNV retinitis. And here again, you can see that he had multiple choroidal lesions, but actually in the right eye, only one lesion, which was accompanied by a secondary CNV. Because this is very unusual that you have a choroidal involvement in CNV, and I'm not aware that it was ever recorded or presented, so I didn't find anything in terms of this. I'm aware of an ARN case, I think, which shows a secondary choroidal involvement, but no CNV case. We were very worried that actually the patient has, due to the fact that she's under immunosuppressants because of a kidney transplant, she may have also developed some tuberculosis or some non-TB or atypical mycobacterium infection. So we worked her up for that, and she was negative for TB and also negative for syphilis and showed an unremarkable chest X-ray. We didn't perform an AC cell tap in order to rule out any atypical mycobacterium, and just because she had no inflammation in the anterior segment, and so we decided to wait and see whether she develops new choroidal lesions. And of course, for her active CNV, she received an intravitreal injection in the left eye. How she presented 2 months thereafter, you can see that there's still some slight intraretinal fluid present in the left eye, adjacent to the CNV lesion. So the patient was continued on anti-VEGF treatment. But what you can see now in the right eye, that actually the CNV lesion, which was inactive initially, has become active. And when you look at the on fast OCTA scan, you can see that actually the initial CNV lesion has already grown in size here. So this is the baseline picture in comparison to it. So the patient was also started on intravitreal injection on the right side. This was done in February 2020. When we look at the fundus images, you can see that now the CNV retinitis is inactive. No more hemorrhage present, no more new active retinitis lesions, and gladly the patients didn't develop a retinal detachment. And when you look, you can still that actually there were no new choroidal lesions. You can appreciate some hemorrhage here, which was still due to the activity of right eye. This was then the last follow-up in March 2020. You can see in the OCTs that actually there's no lesions present. So you can see that there is no activity in terms of the choroidal involvement. So what can we learn from these? Actually, it's sometimes challenging to differentiate inflammatory CNV from inflammatory lesion using FA, in particular if it's a type 1 lesion. And intraretinal and subretinal fluid may not be present on OCT despite an activity. And OCTA can actually help you in differentiating inflammatory CNV from these inflammatory lesions in your clinic. The next case I want to share with you is a 55-year-old Caucasian woman which had 3 months of floaters and blurred vision in both eyes. You can appreciate when looking at the color fundus images these creamy whitish choroidal lesions in both eyes, the phlebitis, which is present in the fluorescein angiography, and also multiple hypofluorescent lesions present on ICG. And I think it's a very straightforward diagnosis here. So the patient was HLA-29 positive and was diagnosed with birdshot chororetinopathy. What is interesting is with the wide field OCT angiography, we saw corresponding to the Pichi that she had multiple areas of flow attenuation identifiable. So you have a big advantage here now from ICG, because you can really tell the depth of the lesion here, and you can tell that actually the patient is really a recent onset birdshot, and that the disease really did not progress already. So it's really the first time, and the disease may have been present for maybe 3 to 6 months. We started the patients on oral steroids and also on disease-modifying antirheumatic drugs. And this is then how the choroidal slab looked, prednisone and DMARD treatment. You can see that the initial now assume that the lesions are still present, maybe really real flow void lesions, really due to the disease and not due to blockage due to the inflammatory cells presence in active disease. What we also did and looked at was the wide field retinal thickness maps, and you can see here very nicely that the wide field thickness maps correspond to the phlebitis present in fluorescein angiography. You can see some perivascular thickening and also some thickening around the optic nerve corresponding to a hot disc and the periphlebitis present in this patient. And correspondingly also to the decrease in the lesions visible on OCTA, you can also see that the perivascular thickening initially present significantly decreased under oral prednisone. So what we currently do right now in these kind of patients is that beside their yearly workup for Goldmann visual fields and full field ERG to assess progression in these kind of patients, we also perform the wide field OCTAs and wide field retinal thickness maps. And so you can really follow the patients over the course of their disease and have an additional tool to assess disease activity. So here you can see the choroidal slabs and the wide field OCTA maps of the choroidal slabs of these patients over the 4 years. And you can see actually that the number of lesions in the choroid haven't increased. And also the choroidal slabs were completely unaffected in these patients. And also the retinal thickness maps remained unremarkable over the course of time. So the challenge we address here that in kind of birdshot, but this is also true for example, the Pichi cases, it's sometimes very challenging to monitor disease activity and progression. And FA and ICT is very consuming, and it's impossible to perform it every time the patient comes in and isn't sure whether he has seen more floaters or whether he's seen more flashes or anything. And the lesson we learn here that you can use OCTA as an additional tool to monitor the disease. Of course, when we look at birdshot, it's not the only one. So you should also look at full field ERGs and Goldmann visual fields in order to follow the patient. But the additional tool you have here, it allows you to evaluate the lesion depth. And so you really have a good insight in the disease progression. And I think what is also important that you can reuse the wide field retinal thickness maps to monitor phlebitis and the possible hot disc. And you may really replace it if you see it initially when the patient presented baseline for a fluorescein angiography. So you do not have to perform fluorescein angiography every time the patient comes in. With that, I really want to thank you for your attention, and I hope you enjoyed the presentations, and I'm really looking forward to your questions. Thank you.
So thank you again for the presentation there, Dr. Munk. I'm sorry there were some audio hiccups. The power of doing things live is we're dealing with the traffic, the global traffic of the internet, I think, is the US is waking up across the country, and Europe is getting their Netflix started. I think we're or at a challenging spot for bandwidth. So it's really, to me, one of the greatest images I saw was that one where you had 4 years worth of Plex Elite montaging going on. Was kind of great to see that. But let's take a look at some of the questions we have here. So can you differentiate from active and inactive phlebitis on using this technology?
So what I'm usually doing is when I perform a fluorescein angiography at baseline with this patient, I also do I look at the wide field retinal thickness map. And if I see corresponding perivascular thickening, then I use the retinal thickness map to follow the patients. However, I have to say, if it's very subtle and it's really only the only smaller vessels are involved, it's sometimes hard to appreciate on the wide field retinal thickness map. And then, of course, it's not a suitable tool to follow these patients, and you still have to perform a fluorescein angiography. And I would say about 2/3 of patients, I really get retinal thickness maps I can use to follow them.
Got it. And so now here's can SSOCT swept source obviously differentiate active choroidal lesions from inactive in cases of A29 disease, HLA-A29? Very specific on the ask.
I think if you have only one scan without any other information, it may be really hard. What you can do, because the thing is, you don't know. You see an area of flow attenuation, but you don't know, is it flow attenuation due to blockage, due to lymphocytes and inflammatory cells present right there right now, or is it really due to real flow void due to ischemic processes and degenerative processes in terms of the disease. But if you use it and you have information over 2 or 3 courses or examinations, then you can tell, because then when you know that you treat the patient and the lesions go away, then you know it was just blockage due to inflammation, while the lesions who remain, you can be more or less sure that it's probably due to destruction. Of course, there's still a possibility that you haven't treated the patient adequately, but then you have to look again, and you have to look at it in conjunction or in addition with the full field ERG to really see how much inflammation is going on, and how much real destructions you already have in the scans. But from my perspective, I don't know how others do. I'm really having a hard time reading the ERG, so I always need somebody else to confirm my conclusions out of it. I don't know, Francesco, how you see it, but yeah.
So can I ask a question to Marion?
Yeah.
So when I was following a birdshot patient with FA and ICG, I always got the feeling that the retinal disease and the choroidal disease, they progress independently. So sometimes when you treat the patient with immunosuppressant, the choroidal disease responds beautifully, but then you still have leakage. Now, are you getting the same sensation just using OCTA?
Yeah, so I totally agree, and I think we've also seen these with the birdshot patients treated with Retisert, that a lot of these patients, they calm down in terms of their retinal activity. However, when you performed an ICG, you saw there were still multiple hyperfluorescent lesions present. And actually, the patient still had an active choroidal disease, but an inactive retinal disease. And there is sometimes a discrepancy. So I sometimes see patients, for example, who show a phlebitis, but in terms of the ICG, they're quiet, and vice versa. So I think these are 2 components which have to be taken into account, and I think it's a very important question. That's a very important question, and a very good point you raised. Yeah.
Sure. Here's a question from Brandon Luan. Again, I appreciate him getting up for the 7 o'clock start, and he's probably got clinic to get to. So in the second case, can you tell on the structural OCT which lesion was CNV versus inflammatory?
On the structural ones?
That is the question. Can you tell on the structural OCT only which lesion was CNV and which was only inflammatory?
Yes, in this case, it was really possible, because in the cases where no, in the left eye it was possible, because it was the case that we only had activity in terms of intraretinal fluid where the lesion was present, while in the right eye I didn't show all the different B scans, but there was a lesion which didn't have a CNV. but showed some kind of activity in terms of the B scan.
Sure. And one more question, maybe both of you can answer this as we go through it. So in cases of multifocal choroiditis, how does OCTA compare to autofluorescence for monitoring and following up of patients?
Can I go first?
Yeah.
Sure.
So for me, in multifocal choroiditis, autofluorescence has some issues. I love autofluorescence, but multifocal choroiditis has you have some masking from pigment, then you get some hypoautofluorescence that shouldn't be there. So in those cases, I always follow my patient with OCTA, I have to say.
Dr. Munk?
Similar, yes, me too.
Okay.
So it's usually at the beginning and.
Well, I appreciate the time that you've taken to put these presentations together. We do want to follow up with this last poll question here, where we go back to see if how this changed. But again, we appreciate your time in putting these together. I'm sorry again for the technical glitches that are happening with our internet traffic. These will be made available on demand on the site that we'll send out, so people can follow up with it there and have their own timing to try and get the internet technical issues sorted out. So again, thank you. Let's go ahead and see how this changed, this question over time, to see if it's CNV is still as far a leader as it was in the earlier polling. Not as far. The choroidal disease has definitely come up. You guys have definitely had an impact on this. So congratulations on educating our viewers. And again, I thank our viewers for taking the time to join. But I appreciate your time, not only for putting these talks together, but for coming and putting this together. So thank you again. I hope you guys have a great rest of your week and enjoy your weekend.
Thank you very much for your
You
invitation.
too. Thank you.